thanks again for coming out, and we'll get started with introducing Dr. Kevin Spear.
Well, welcome. Thanks you all for coming out. As Paul said, we're happy to have you all here tonight talking about the shoulder. Many of you have been here before. We've had a number of these symposia, and this one is a little bit different. I think the previous ones have been more towards some anatomic issues or certain narrow areas within the shoulder. This is sort of more of the view of the shoulder outcome from perhaps like from 20,000 feet. And I would sort of title my talk as Strategic Approaches Towards Optimizing Outcome. Outcome gets a lot of play these days. And as we know, outcome is, the patient has their own outcome perspective. I have my perspective. You have your perspective. And much has to do with your experience and knowledge and all. And our situation is best enhanced the sooner that we in the room collectively as a physician and physical therapist understand that it's the patient's perspective that matters. So many times, it's remarkable some patients what they can be happy with, and many times I've had to learn to sort of limit my disappointment that the shoulder isn't as mobile or isn't as good as I'd hoped it to be clinically, whereas other patients seemingly have a very good shoulder and something is still not right. So certainly fulfilling expectations, as we all know, trying to set a bar that's achievable and not to misjudge too much by giving patients false expectations. So the central tenet of outcome, and much of this I think I'm preaching to the choir here in the sense that my belief within the shoulder, and I do probably 90% of my practice is shoulder now, is the importance of physical therapy for the patient working with a physical therapist, because the outcome, regardless of shoulder problem, you got to restore the full passive range of motion, restore some durable strength, and then that lets you restore function, especially with overhead activities. A lot of patients who have bad cuffs, arthritis, things like that, who remarkably have little pain, when you keep them down here, they're pretty good. It's getting their elbow away from the side that's really the test of the shoulder, because that's what brings the rotator cuff tendon into play. I just want to review some anatomy. It's always good to review it. So the humeral head and the socket make up the glenohumeral joint. The humeral head is modeled after a sphere, essentially a third of a ball. And shoulder motion is all rotational. So if you put a dot in the middle of the humeral head and move your arm around in space, that dot doesn't move but about a millimeter or two. So translational motion is really occurs at end range of motion, the coupled motion, and it's pathologic. If you get too much anterior translational motion, it's anterior instability, or say it's the same with posterior. And same with superior, because if the humeral head is going up, it is pinching the rotator cuff and biceps area against the acromion, and that may be a part of a tear, and that may be a part of the process. But the socket here has a lining, that's a labrum, that's a fibrocartilage. That's where these ligaments attach. And the ligaments is more of a confluent cuff. And the ligaments in the shoulder are about as thick as a playing card, maybe 2 millimeters at the most. They're they're not terribly impressive. In terms of if you were to be at a time of arthroscopic surgery and you're sort of trying to, grabbing them and moving them. And the ligaments in the shoulder are naturally loose. The shoulder has enough volume, in the shoulder joint that it could contain 2 humeral heads. So the shoulder, normally, the ligaments don't become taut, don't become tight until you get towards the end range of motion. So all the central, maybe 70 to 80% of range of motion is generally rotator cuff, co-contractions, things like that, controlling stability, not so much ligaments. The front of the shoulder, the rotator cuff covers it as a hood. Subscapularis, Then the top, then this groove here is the bicipital groove where the biceps should be depicted, but it's not. Then the supraspinatus. Then if you go in the back, infraspinatus and teres minor. Now, if you look at the bulk of muscle, the volume of muscle, that of the subscapularis is equal to the supraspinatus, infraspinatus, and teres minor combined. So whenever people talk about co-contractions and balancing anterior and posterior, it's really balancing across the bicipital groove. I thought this sort of shows it in a similar fashion. An anterior look at the shoulder. Now this one does show the bicipital groove here, and this little blue thing is the little bursa sac, which we'll talk about more later. But you can see, it's aligned on the posterior or posterolateral aspect of the rib cage, and about 1/3 of your motion is through the scapula and all the scapular rotation here. And what we're talking about tonight is glenohumeral problems, and we're going to get in tonight, challenging issues with stiffness, which is the bugaboo of the shoulder. It really is. But we're not going to talk about that, and then the neck hurts, or the scapula hurts, or there's myofascial pain in the back, or there's radiating discomfort. I mean, there's a myriad of things that can start to pile up around the shoulder. We're just talking about stiffness tonight. So to me, the central tenet of outcome is physical therapy for the patient, and working with a physical therapist, because I think that patients need to be educated about how to rehab their shoulder. It's not intuitive, because normally if you would query, I've done this innumerable times, you'll query them about exercising their shoulder. What they describe is something you'll do in the gym. Rarely does anybody describe anything remotely of what might be a reasonable rehabilitative effort, especially more of a mild to moderate effort. I think guidance to do it properly, especially if certain arcs of motion. Sometimes they'll say, well, I want to do such and such, but it hurts or it's bothersome. Well, you change your motion arc, change it. Try to find, at least early on too, find something you can accomplish. Reinforcement and certainly encouragement. I mean, I think part of physical therapy, it's beyond your education and your training and the applied science. It's a real clinical bonding profession, because patients have to entrust themselves to you, because generally what you do causes discomfort, and they have to believe that this is worthwhile. And obviously I have to enjoin that, but they have to believe it, and they do. But it's not. And many times I'll tell patients, especially patients who are getting a little stiff, I say, if you're coming home from physical therapy, someone say, well, how did physical therapy go? I say, I was great today. Shoulder feels better. Therapy didn't hurt at all. I said, well, you're probably not pushing it hard enough. And there's a fine line between not pushing it hard enough and pushing it too hard, and that line can be tough to draw. Some patients it's not so hard, but some patients it is tough, as everyone knows. The challenge from your perspective and from my perspective, thinking about therapy, is when to begin it. When to begin it. And how aggressive can it be? Can it be pain as the guide? Can it be sort of progress as pain permits and as your motivation and enthusiasm allow you? Or is there some protocol? Is there some parameter that is needful so that you can be assured that the reconstructive component of the shoulder or the repair component isn't being adversely challenged? And much of that is, I think, from a physical therapy perspective, and as you all know, this who've done it, you got to know what type of surgery was done, the specifics, because shoulder surgery, and again, as an orthopedist, I try to keep things as simple as possible because it sort of enhances my effort when I can. Shoulder surgery is really in two big piles. There's debridement and ablation surgery, and there's repair and reconstructive surgery. I mean, and you can lump everything in the shoulder in one of those two piles. What I mean by debridement or ablation, the shoulder, it's not unique, but it is not, it's one of few areas of the body. As we get older, things happen in the shoulder. The acromion gets spurred. The coracoacromial ligament can thicken. The AC joint, or the distal clavicle, can become osteolytic, or the AC joint can become arthritic. The bursa underneath the acromion can become thickened. It can become inflamed. The rotator cuff typically softens a bit. It can be partially torn. The labrum can partially tear. And a number of things can occur, and these problems can defy non-operative treatment. You know, a course of anti-inflammatory medicines or injections or physical therapy, it can defy it. They have interfering pain because and part of the reason, as I tell patients, that this stuff is mechanical. You know, so if you go to physical therapy, say you have an acromial spur, a partial rotator cuff tear, some bursitis, and you go to physical therapy and you're doing terrific. Great. But you still have the acromial spur and you still have the partial tendon tear. You're just doing terrific in spite of that, which means the solution has to be sustained because you can't get over that mechanical problem. It's like having a rock in your shoe. It is what it is. Now, if you can coexist with it and it doesn't bother you, great. And most people, it doesn't bother them. I mean, everyone, I say over the age of probably 55, if you took x-rays of their shoulder, will have a bit of a acromial spur, some AC joint distortion on x-ray. Just like, you know, they talk about, you know, if everyone over, I think over the age like 35 got an MRI of their lumbar spine. So you have to be careful. I mean, there are some age-related changes, and the shoulder manifests themselves quite a bit. So the things that are just ablative, that are common, so here's another picture of a shoulder. Here's the clavicle at the top, the acromion, the AC joint. The humeral head would be here, the glenoid. That's a rotator cuff. So the acromion can become spurred and pinch this bursa. It's called impingement syndrome. We remove the spur. The coracoacromial ligament becomes thickened. You can cut that or remove it. This bursa becomes very thickened, hypertrophic. That's what a lot of crepitus is, a lot of the coarseness. That's why it hurts raising over here. This bursa is a pain generator. That can be removed easily. The AC joint here can become arthritic. Now, you know, in the human body, the singular example that you can cure arthritis with joint resection is the AC joint. Now, you can get away with it in the elbow, generally. You know, some patients get some wrist pain, but it's not quite right. Sternoclavicular joint, you can, but it's not as predictable. In the shoulder, if you can do this thing arthroscopically, and basically if you can remove the end of the collarbone and leave the ligaments unharmed, I mean, like shell it out, the body doesn't know it's gone. So you can have an arthritic AC joint and a painful AC joint, and it's curable. Any other joint in the body that becomes arthritic has no such solution. You just don't carve out the joint. So this, and the main reason that physical therapy is so essential in the shoulder, especially for these debridement procedures or ablational procedures, is this bursa. Because it's removed, you have to regrow it. You know, bursa grows anywhere in the human body where two tissues move relative to one another. So this bursa has to be regrown, and you guys help regrow it. Why? How? Restoring range of motion. So, you know, usually a bursa should be almost like a monolayer of synovial cells. So this bursa has to get regrown, and if these patients don't rehab, they don't move their shoulder, this thing's going to scar down. I mean, when I get done with it, when any orthopedic surgeon gets done with it, it's a raw space, and they have to move it. And in these shoulders, you know, all we've done is remove things. We've cut something out. We haven't repaired anything. There's nothing to protect. This is another example. The bursa in the shoulders is quite big, and the bursa is the pain generator, generally speaking. I mean, the joint can become synovitic, especially in a frozen shoulder, and there's some other things that occur in the joint. But the bursa in the shoulder, which is why, you know, cortisone injection has some efficacy in treatment. But, you know, how does the cortisone injection work? Well, I mean, it can mitigate some of the inflammation, but it doesn't solve anything. But, you know, if If what they've had is some unique flare-up of their shoulder, it might be effective. Now, repair surgery, so is everything else. So the labrum can be torn, that can be repaired. The rotator cuff can be torn, that can be repaired. Shoulder replacement. End-stage glenohumeral osteoarthritis, I'm putting in a prosthetic humeral head, a prosthetic glenoid, and yet you have these protocols for precaution. The prosthesis, when that patient leaves the OR, that prosthesis is as stable as it's going to be at that point, hopefully, 5 years later, 10 years later, or beyond. What you guys are rehabbing is the subscapularis repair. That's what you're rehabbing. If we could magically do a shoulder replacement and not take down the subscapularis, that'd be awesome. That is not the way God made the shoulder. I mean, you got to get the shoulder somehow, and that's how we get in. So, AC joint reconstruction and fracture fixation are things that are distorted and are put back together. So in the glenoid, here's a cartoon of a glenoid. The labrum's around it. Here's the biceps tendon, and the labrum can be torn at the top, and the front, and the back. Generally can be fixed arthroscopically, but it has to be protected. This is not something. The thing about arthroscopic surgery or repair is that it's minimally invasive. Great, it's doable. Yes, but sometimes it's not as strong structurally as open. So you have to be a little bit more cautious with it. The ligaments, here's the humeral head, the glenoid, just showing the ligaments here, and sewing those things together, tightening them up, trying to restore normal length tension relationships. That has to be protected. Rotator cuff tendons. Here's a humeral head. This would be like a supraspinatus tear. The bursa on the top would be inflamed. Normally there would be like a bone spur here on the acromion. But if someone has a symptomatic rotator cuff tear, and this is a little bit different, we'll talk about this a little bit more, but, previously the labral tears and the ligament repairs, generally younger folks, younger people, maybe certainly less than 35-ish in my experience. Because when younger people of that age range have an injury, the weak link in that shoulder chain is the ligament and labrum. When someone 40-ish, 50-ish, 60 beyond has injuries, usually the tendon starts to take the bulk of the stress. The stress gets dissipated usually through one channel. So that's chain breaks at one link generally. So the challenge with this. And this is a lot of what I do, rotator cuff repairs. I'm sure it's a lot of what you guys, rehab. There's a duality of issues here. One, I've repaired it. But talk about protection. A lot of these things tear because they're dysvascular to begin with. These tendons tear because the tendon is no darn good to begin with. It's degenerative. It has fatty deterioration. It looks dead, look like a piece of gristle on the end of a chicken bone. So I've repaired that, and at some point, we have to protect the shoulder to let it heal. But if we overprotect it, the shoulder's going to get stiff. If we underprotect it, I'm going to risk this thing tearing, and so therein lies the challenge, and that has a lot to do with the subsequent two talks after mine. Fracture fixation, a lot of that has to do with the quality of bone, and hopefully the surgeons will sort of tell you how much these shoulders can be moved. Fractures get stiff. I mean, someone could have a surgical, like here's the humeral head, it's a surgical neck. Someone could have a surgical neck fracture tonight, and we could fix it tomorrow, and I could say, my God, I got great fixation, the bone is terrific, and I'll start rehab in 3 days. It'll still be stiff. That's fractures. And you don't have to warn patients a bit. I mean, fractures, it's not always the case, but generally fractures tend to get stiff because the shoulder fractures, there's a lot of other humeral and inflammatory mediator things that occur around the shoulder girdle. The prosthesis, we talked about the subscapularis repair, and AC joint reconstruction. This is a much less common procedure. One of the challenges of an AC joint reconstruction, so what it means is sort of here's the clavicle, and here's the coracoid, part of the scapula, and so the ligaments distort, and the clavicle elevates, that separates. And if that's pathologic, that has to be repaired. This is hard to repair. Well, it's not hard to repair surgically. It's hard to get the thing to heal, which means we typically really protect these things. I'll put these things in a sling for 6 weeks. Shoulder's going to be stiff, but not as bad as you think because the surgery didn't enter the subacromial space or the glenohumeral joint. Shoulders aren't quite as stiff. They're deconditioned, really deconditioned. But they're not as stiff as, I've always been pleased that, they don't, just because you've had some regional big surgery in a sling for 6 weeks, there's just not some obligate frozen shoulder. Generally, that doesn't happen. My primary concern of physical therapy, because I'm an advocate, I prepare patients for it, I generally tell patients that surgery enables the shoulder to get better. It removes the barriers. I can remove a spur. I can remove painful bursa. I can repair a torn tendon. I can structure. I mean, surgery is a mechanical event. We repair things, we remove things, we tighten things, we loosen things. That's what surgery is. So if something has a mechanical problem, surgery is well suited for it. So my concern is there's something in the shoulder that I've just done that needs to be protected and could be potentially disrupted by physical therapy efforts. Rules of thumb in orthopedics, which we all have rules of thumb, but this is what we're trained to do. This is what I was told 20 years ago, and I still sort of hold to it. Ligaments and tendons, about 3 months until you can push as pain allows. So in my practice, I'll generally take rotator cuff repairs, and you'll hear in a minute how I prefer to do them. And there's lots of ways to do them. So what you're going to hear tonight is much of sort of how I've learned to do them. It's one approach. But I'll take them to the point they're about 3 months after surgery, and then at that point, hopefully they're independent. I'll let them progress their activities as pain permits, encourage them to use it, encourage them to push it. They've learned a lot from the physical therapist. So once you get beyond 3 months, I am philosophically with the patient changing gears towards, okay, let's push the shoulder. It's okay to push into it. It's okay to do stuff that hurts more. If you do something that is more painful, at this point, I don't think what you're doing is harming the repair. And generally, that's what patients need to hear from me. They really do. It's amazing. It's not that they're unwilling to make the shoulder hurt. They're anxious about making the shoulder hurt. Now, part of it is that I have to have some degree of confidence because, I can't miss the judgment on that too often because patients are entrusting that if I'm willing to push the shoulder, you've told me that it should be healed enough. Yes, and that generally is my approach. It could be adjusted, especially by patients older than 70. Some of those patients, but some of those patients, it's not as a big an issue anyway because they're not going to push it as hard anyway. But if you get this older than 70 patient who is determined that they're going to play golf and they're going to exercise 3 times a week, or if they want to go for the grand prize, they want to play tennis. My older than 70 patient, degenerative rotator cuff tear that needs repair, who has stated goal that what's going to make them happy about their outcome, they want to play tennis with their dominant arm. That's a challenge. And it's fun. I enjoy doing it, but I'll tell them ahead of time, say, look, this is tough. This will require a lot more therapy. If you're willing to give up tennis and just play golf, life is simpler. But it's not my decision. It's their decision. And if they want to go for it, so let's go for it. I like protocols because I like to be able to communicate to physical therapists about where I think the shoulder can move at a certain period of time that is safe. Doesn't mean it doesn't hurt. It just means that it's safe. Because it sort of helps deal with this quandary of motion versus healing. Because you have to respect the needful biology of the surgical repair. It just takes a period of time. And yet, while the shoulder is being protected, it's stiffening, period. How much? It varies, as you know. You know, some patients amaze me; they don't get stiffer, and I mean, there are variables beyond the degree of their pathology. Some patients, you know, just like it's almost a frozen shoulders, can develop without significant antecedent trauma. There's an inflammatory additional variable that comes into play in some patients and not in others. But generally, I like to promote motion early to avoid stiffness. And if patients have access to pools, we're getting a period of year where it's not as common. Where in the summer, I mean, I talk to a lot of patients, you know, aquatic therapy, moving it in water, great. You know, it's a nice, safe environment if they're willing to, you know, get in their bathing suit and take showers and get out and shower again. A lot of patients don't want to do all that fuss. You know, certainly our first principles are do no harm. I just thought this was an interesting example is that, you know, so imagine this patient's had rotator cuff repair surgery. She looks way too young for that. But anyway, just pretend that she's, you know, so pretend this is a 65-year-old woman with a degenerative cuff tear. You know, probably been torn for 2 years, progressive, failed non-operative treatment, a little bit of atrophy in the muscle. It repaired well, and here she is, and your surgeon is sort of letting her go up to, say, 140 degrees of elevation. Well, here you're hitting about right here, and this patient is articulating to you the following concern. That hurts. It feels like you're tearing up the surgery. So at some point you have to, the physical therapist, I mean, that's tough. I think it's extremely tough. You have to have a confidence to say, yes, it hurts, but I'm confident that we can push it. And I'm not sure, absent a protocol, or if your surgeon hasn't told you how far you can go, that's a tough call. And if you don't know how far to go, and you edge on the side of caution, which is what we should do in medicine. You know, uncertainty, default to the more conservative tack. The shoulder's going to get a little bit stiff. But stiffness is always a part of shoulder surgery. The shoulder has more motion than any other joint in the body, and it wants to get stiff after surgery. It wants to swell. And for those of you who've seen post-operative shoulders, and I'm sure you all have, you know, the shoulder, I tell patients, it's not a good container. So, as an example, a knee. Someone's had knee surgery, say a knee scope, and they got a lot of swelling. The knee capsule usually contains it, and that knee can look like a balloon. It's thick, it's swollen, it's killing them. It's big and swollen. The shoulder, not so much, because the shoulder decompresses itself because the shoulder doesn't hold its own blood. The blood will flow out. It'll flow out through the bicipital groove. It'll flow out through the rotator interval capsule. In the subacromial space, you've removed the bursal margin, so that's why, you know, you see patients with arthroscopic shoulder surgery. They can be black and blue down to here and by the elbow, and sometimes in women it'll follow the tail of the breast, and all of a sudden they'll be black and blue here, and you know, it's crazy. And the shoulder decompresses itself. That's the bone spurs. That's the bone bleeding. That's the shoulder bleeding. Except the blood doesn't stay there. It flows out of path of least resistance. So, you know, I always warn patients, because otherwise it's a phone call when they look in the mirror and say, "Holy Christ, my arm is black and blue." You know, something can't. You know, I'm black and blue down to the elbow. What happened down there? You know, so. But stiffness is always part of it. Pain, swelling, inflammation. Now, much of this is the domain of the clinician, but I think it's your prerogative and your duty to prompt them. You know, controlling pain. Pain can be controlled. I mean, to some extent, there are medicines that can control it. Narcotics, if it's needful. Acetaminophen, if it's not so bad. Tramadol, non-steroidal anti-inflammatory medicines. I encourage patients. You know, are you taking your medicines? Do you need to take your medicines? Because if the shoulder surgery if the shoulder physical therapy is not progressing ideally, pain may be a barrier. Controlling inflammation is important. Anti-inflammatory medicines, and if it gets bad enough, prednisone, as long as they're not diabetic. Don't get prednisone to diabetics, because corticosteroids can exacerbate diabetes. Well, it will. It'll drive their sugars up to some extent. Maybe a little, maybe a lot, unknown how much. So it's best to avoid it. Control swelling, cryotherapy, cold therapy. I'm a big advocate of that. And if you've ever had a shoulder injury, keeping your shoulder above your heart. Just like everybody who sprained their ankle, has a big old swollen ankle, figures out pretty soon if you lay flat and get your foot up, it feels better. Just the hydraulics of swelling, the injured part above the heart. Well, to get the injured shoulder above the heart, you need an upright torso, meaning you're sleeping sitting up, meaning lazy boy chair, recliner, propped up in bed, something like that. So to me, the duality of surgery quandary for me is restoration of motion and function and protection of the repair and the promotion of biology. So this is the segue to the next two talks. Carrie's going to talk about the routine rehab and protection, and then Paul's going to talk about the excessively stiff shoulder. But the last thing I'll leave you with, what I tell patients is, especially with rotator cuff repairs, I said, what I want ideally at 3 months is a near full range of motion and a healing cuff, and they're off to the races. That's choice A. Choice B is a healed rotator cuff and some stiffness and deconditioning. That just takes more time, effort, therapy, patient motivation, encouragement, all that. Because that can be worked out with time and effort and guidance with physical therapy. Because the thing you don't want, if at 3 months after surgery, the tendon has torn apart. So that's why I tell them, if patients are struggling, and we're having stiffness, and the therapist, and it's just not, it's tough, and we've all been there. At some point, you have to choose. This shoulder is wanting to get stiff, but if we push it much harder, we're going to endanger the repair. Where do you balance? Promote healing. Get that thing healed, because healing, once it's healed, if it's just stiff, if it's just weak, that can be worked through, usually. If it's torn, if it didn't heal, then you can do all the therapy on God's earth, and that won't heal it. So, if we can have it all, that's great. But sometimes I tell patients, look, we got to back off, because therapy is just too painful. I can't seem to control your inflammation well. And if your shoulder's going to get stiff, we're going to have to allow it to get stiff, because we have got to get this thing to heal properly. So, at some point, even though your objective and why they're seeing you is restore motion, restore strength, restore function, it's sort of it's why computers will never do physical therapy, right? Because there's a judgment as to when enough is enough, and when do you have to sort of say, we need to sort of back down or change tacks here, because if we keep going to this path that we're on, we could have problems. And to me, healing, that's what I want. I want it to heal. If it's healed, the rest of it, time, effort, new therapy, new strategies, different ideas, get in the water, go to the gym, let's stretch, let's try whatever. That can all work. If it doesn't heal, that's a challenge. If it doesn't heal, the surgery has technically failed. They're there at surgery to heal that which is torn. And if that thing's not healed, and if they still get better, then that's just lucky. It is. If a cuff didn't heal, but they still have a great range of motion, and their shoulder feels better, and thank God, removing the spur helped and all that, that's great. But it's not always that way. So when a judgment needs to be made, promote healing. So, Carrie, with that, why don't you come up, and you can talk about our routine rehab, and then Paul will has the unenviable task.
Good evening. Tonight I'm going to be talking about the normal course of rehabilitation following shoulder surgery. So, following surgery, there are two main pathways that we can go along during rehabilitation, and this is largely determined upon the type of surgery that has been performed. So, in a surgery that has been an arthroscopic surgery where there's debridement and ablation, just like Dr. Spear talked about, such as a subacromial decompression, distal clavicle excision, In all of these situations, there's nothing that's necessarily been repaired. So the patient is placed in a sling for 3 days, and then they present to physical therapy immediately after that. As we go through therapy, basically the patient's tolerance for activity is how we determine the progression. Are they in pain? We can manage that pain and then sort of progress without really worrying about damaging anything that was done during the surgery. On the other hand, when there has been some sort of repair that was done during surgery, we are much more concerned about maintaining the integrity of that repair as we progress through our rehabilitative efforts. So examples of these would be the rotator cuff repair, the total shoulder, labral repair, an ORIF. In all of these cases, the patient is placed in a sling for 3 weeks, and after that time, then they present to physical therapy. So essentially, they're immobilized for 3 weeks, and we understand that there is going to be a lot of stiffening that occurs during this time. But again, our number one goal is to make sure that the repair has been completely healed at the end of the day. So stiffness within the shoulder typically occurs following immobilization, and then also inflammation and synovitis within the joint. These things in combination can cause structural changes within the ligaments and the shoulder capsule. The contracture and the tightening of the capsule actually holds the glenoid much tighter, the humeral head against the glenoid much tighter, so the range of motion is limited by that. Adhesions can also form within the joint as well, which really limit the amount of motion available. The rotator cuff, for example, is notoriously difficult to heal, and there are several reasons for this. The tendon to bone interface is not necessarily very conducive to healing. The body does not readily want to heal at this interface. And then also, typically people who have rotator cuff tears are more in a middle-aged population rather than a younger population that would heal more readily. And in the middle-aged and older populations, there's senescent changes, there's degeneration occurring in the tendon prior to the repair. So there are fatty infiltrates, the tendon may have retracted from the bone, the muscle has begun to atrophy. So all of this sort of is not very conducive to healing. In the literature, it's reported that it's up to 20 to 65% failure rate for a rotator cuff repair, and this commonly occurs as the tendon avulses from the bone. As physical therapists, the most important thing for us to understand is that oftentimes this failure occurs during the early stages of healing. So we actually see these patients when the repair has not fully healed. They're immobilized for 3 weeks, but then in that period of time right afterwards, the repair is not necessarily solid. So we still need to worry about protecting that. So the protocol, as I've talked about, the initial stages include immobilization of the shoulder. The patient is placed in a sling to protect the surgical repair at the sort of sacrifice of the mobility of the joint. The patient is encouraged, however, to flex and extend the elbow, use the hand for small motions, but no lifting or holding anything heavy in that hand. So we can kind of make them a little bit more comfortable and prevent any other joint contractures while we're still protecting the shoulder. Now, as the patient progresses and moves into the second phase of therapy, this is when they begin their treatment with us. I think it's important that we educate them on our goals in therapy and the reasons that we are progressing in this paced, deliberately sort of slow progression through rehab. We want to emphasize that it's important to make gains in range of motion and to help the shoulder become more flexible, but that we are still trying to protect the repair. So we have limitations to the range of motion that the surgeon has sort of set. So elevation to 140 degrees, external rotation to 40 degrees, internal rotation to the level of L1. And I think it's important to just let the patient know that even if we can achieve those sort of limits to the range of motion prior to the end of this phase, that we still won't be moving towards full range of motion until after this first month of therapy is completed. At this time, it's important also to sort of address the patient's pain, make sure that their pain and inflammation is well managed, and then also sort of understand where we are in our range of motion as we're stretching the patient and working with them, and taking into consideration how they feel and their level of pain at the different points of the range of motion. At the initial evaluation, we make our observations of the patient. Are they wearing the sling? Is the shoulder, are they holding it in sort of an internally rotated, protected position? Can you already sense that there's some stiffening that's occurred? Or on the other hand, have they removed the sling and they're opening and closing the door with that affected arm, and we sort of have to rein them in a little bit and say, we still need to protect the repair, even though we've said that you can take off the sling. At this time, the patient history is also important. Patients who are diabetic or have a frozen shoulder prior to the surgery, typically we're going to see that they're more stiff following surgery. So we can assess the patient's passive range of motion at this time. And at this time, I think it's important that we check to see what factors are actually limiting their range of motion. Is it pain? Is there pain and then you feel that there's some stiffness? What does the end feel like? And how is the joint moving as you assess in different planes? Also, quick check for elbow range of motion here, just to make sure there's no elbow contracture after being in the sling. Treatment options at this time, our first goal will be to manage the patient's pain, and we can do this through a number of different modalities, such as cryotherapy, encouraging the patients to use their whatever form of ice they wish to do so at home, and then also ultrasound or any other pain-relieving modalities. And then if they seem to have a tremendous amount of pain and this is really limiting our rehabilitative efforts, and we can't actually do anything in therapy without the patient guarding against the range of motion or stretching exercises, we can consult with the surgeon, try to figure out some sort of pain management regimen that actually works for them. During phase 2 of the protocol, we can perform passive and active assisted range of motion exercises through stretching, and grades 1 and 2 glenohumeral joint mobilizations only, and then also some very light strengthening exercises towards the end of this phase, mainly through the periscapular muscles. When we are stretching the patient and working through the range of motion and sort of counteracting the effects of the joint stiffness, long duration holds at low loads are most effective for remodeling the tight structures. And we can stretch the patient in a variety of planes, figure out what's comfortable for them, figure out the areas of tension within the joint, and then stretch accordingly. All at the same time, though, keeping in mind your limits to the range of motion that the surgeon has set. This sort of phase really lends itself, I think, to manual techniques and hands-on work with the patient, as a lot of it is passive exercise rather than a strengthening program or active motion. Their home exercise program is crucial at this time to maintain the gains in range of motion that we've made during the therapy session from one session to the next, so that when they present to therapy on their second visit, that we're not back at the same point that we were on the previous visit. When we are thinking about the limitations in shoulder motion and trying to predict the way that the shoulder is going to move, we typically think about Cyriax's capsular pattern. And for the glenohumeral joint, that would be that external rotation would be more limited than abduction, which is more limited than internal rotation. Now, there's some evidence in the literature that suggests that in a pathological shoulder, or one with adhesive capsulitis, that this may not necessarily always be the case. So Mitch et al. Conducted a study in 2004 in which they looked at patients with adhesive capsulitis in the shoulder, and they compared the affected shoulder to their unaffected shoulder. And they found that while external rotation was more limited than abduction and internal rotation, that abduction and internal rotation did not differ significantly from one another. So this just is something just to keep in mind, that, you know, patients with adhesive capsulitis, or if there's some sort of pathology in the shoulder, it doesn't always necessarily behave as we would expect. Joint mobilizations can be performed during the phase 2 of rehab, only grades 1 and 2, mostly with the intent of reducing the patient's pain and muscle spasm, so that then we can sort of stretch and progress through therapy. The motions that we can perform at the glenohumeral joint would be an inferior mobilization, anterior to posterior, or posterior to anterior. When thinking about the way that the glenohumeral joint moves, we typically think about this as based on the geometry of the joint. So the convex-concave rule of McConnell, where the roll and the slide of the joint actually move in opposite directions of one another as the arm is moved through space. Now, as Dr. Spear talked about, there's very little translation of the humeral head in the normal shoulder. And however, in the pathologic shoulder, where there is asymmetric tightening in the capsule, so in adhesive capsulitis, or when there is some sort of pathology in the rotator cuff, the posterior portion of the capsule may become more taut than in the normal shoulder. There's been a few studies that show that because of this pathological tightness, that translation can actually occur in an abnormal way when the arm is moved through space. Harriman et al. Conducted a study in a cadaver study where they passively, obviously, moved the arm through different motions and measured the translation of the humeral head. And they recorded these motions and the amount of translation. And then after that, they operatively tightened the posterior capsule and measured all these motions again. And they found that because of the posterior tightening in the capsule, that there is actually an anterior translation of the humeral head during elevation or during movement of the humerus. So as we're thinking about our joint mobilization strategies and the techniques that we're going to use to counteract the stiffness in the joint, I think the focus needs to be on the tension in the structures, assessing where the tightness lies and what the cause of that is, and then basing your treatment on that. Johnson et al. Conducted a study in 2007 on patients with adhesive capsulitis in the shoulder. They divided their subjects up into two treatment groups. One treatment group, they were randomly assigned. One treatment group received an anterior to posterior glenohumeral joint mobilization, and then the other group received posterior to anterior mobilization. The outcome measure that they were assessing was the amount of increase in range of motion in external rotation. And what they found after these treatments was that the anterior to posterior glenohumeral mobilization actually increased the external rotation more than the posterior to anterior mobilization. So this is important that we understand the geometry of the joint and the convex-concave rule, but that in a pathologic shoulder there may be asymmetries in the tightness in the shoulder capsule that cause translation that we normally wouldn't see. In the next phase of therapy, at this point we sort of trust that the repair is getting close to being fully healed. So at this time, we can actually work more towards full range of motion in the shoulder. So we can educate the patient on, these limitations that we imposed on them early on. We're now lifting those limitations. We're going to be trying to actively use the arm, and that we're going to be pushing towards full range of motion and end range. At this time, we want to encourage them to use that affected side, with the real limitation still being on no heavy lifting and not really overdoing it, mainly to keep any inflammation and adverse effects at bay, and also that the musculature around the shoulder, everything has sort of become weakened over this in the initial 2 months post-operatively. So the biomechanics of the joint aren't necessarily as they once were, or as we hope that they will be when we're all done. During this phase, our treatment options can include grades 1 through 4 of glenohumeral joint mobilization, so more aggressive, higher force mobilizations than were permitted during the second phase. And the goal now can be more on increasing range of motion through these mobilizations. At this time, we can also work on passive, active-assisted, and active motions. Strengthening efforts can be employed as well, and we can work on rotator cuff strengthening, using light weights, using resistance bands, and also periscapular muscle strengthening to really complete the whole picture for the whole shoulder girdle. I think stretching, multiple planes at this point is really important, making sure that we sort of cover all bases with respect to the range of motion and the ultimate goal of the patient having full function of their shoulder, whether it be for sport or work-related activities. And stretching the structures that you find that are tight. So the posterior shoulder, that the rotator cuff interval tends to become very tight and not very mobile following any kind of trauma. So stretching this, I think, is important at this time. So in the last phase, after those, the 3 months of rehabilitation, we can really, know that repair is healed and work towards more independent exercise and progression towards returning to sport and any sort of activities that the patient wishes to get out and use that shoulder.
So I'm going to be talking about the increased post-operative shoulder stiffness. So from here on out, when I mention shoulder stiffness, I'm talking about shoulder stiffness beyond what we would normally expect in a normal progression of physical therapy. So unlike what Carrie talked about, what we would expect to see through that progression. So we'll talk about identifying these individuals early on after surgery, identifying and addressing the specific underlying cause of their stiffness, and looking at specific treatment techniques to help remedy this stiffness. So the incidence of shoulder stiffness after surgery has been very well reported in the orthopedic literature, anywhere between 2.7 to 15% of individuals will develop increased shoulder stiffness following surgery. So fair number. Not a lot, but enough that we see it, we deal with it, and we need to know how to treat it. And some studies have even indicated that in their research that stiffness after surgery is the most common complication following surgery. Much like idiopathic adhesive capsulitis, where we can sort of identify predictive factors or individuals who may be more prone to developing adhesive capsulitis, we found in literature that there's also some predictive factors for individuals who are more likely to present with increased stiffness after surgery. So some of these predictive factors include preoperative range of motion loss, most oftentimes internal rotation, even though they look at it most times in the literature as reaching behind the back, which isn't specifically internal rotation, but close enough. Patients with diabetes, workers' compensation cases, age, and the research is sort of split on age. Some studies say that individuals under the age of 50 are more prone to develop stiffness after surgery, and some say after, so not a great predictive factor. The presence of calcific tendinitis in the shoulder, partial thickness articular surface tendon avulsions and their subsequent repair during surgery, the number of tears they have in their shoulder, in their cuff, the tear size, whether they're male or female, and the presence of fatty degeneration. So all these things have been linked to predictive factors in individuals who before surgery present with these things, and they're more likely to present with increased shoulder stiffness following. Between all these studies, the predictive factors with the highest predictability rate are preoperative range of motion loss and diabetes. So we acknowledge that this increased post-operative shoulder stiffness exists, and we can, with some degree of certainty, identify patients who might be more likely to become stiff after surgery. So why not plug those individuals that we identify into some protocol different than normal population? And that's been some of the research questions that have been tried to be answered in the literature, and not very good results from that. So we look, for example, these are just two recent studies, one by Ku et al. I think it was published in February this year in the Journal of Arthroscopy. They took 152 patients who were going to have surgery by the same surgeon, and 79 of them were identified prior to surgery as having some of these predictive factors that we talked about earlier. All 79 of those patients after surgery were plugged into sort of an early motion protocol. The remaining patients were placed into a protocol that's very similar to what Carrie talked about, the one we follow. And what they found, their conclusion was, I should mention first that basically the big difference between the two protocols was the inclusion of closed chain passive stretches immediately after surgery. So no time in a sling. Basically they were doing table stretches, flexion, abduction, that sort of thing. So what they found, or their conclusion was, at follow-up, that all the individuals that were plugged into that early protocol didn't develop stiffness in their shoulder. Now, their outcome measure for what was considered as a stiff shoulder was the patient's dissatisfaction of the range of motion they had in their shoulder, which is an important variable to consider, but no consideration to range of motion, disability, function, anything of that nature. Plus, if you think about it, those individuals that were plugged into that early phase protocol, typically before surgery, if they're presenting with those predisposed factors, they're probably going to have less range of motion, more painful, so they might be more likely to be satisfied with less of an outcome than those individuals in the other group who received the regular treatment protocol. So there's some variables there that really weren't accounted for in that study. Klinberg also did a study looking at similar protocols, early loading phase, and a regular protocol similar to what Carrie talked about. Low number of subjects, but 7 in each group. And what they found was that at a 2-year follow-up, their big conclusion was that none of the individuals who were plugged into the early loading phase developed any adverse effects, so no re-tears of their tendon. But also a 2-year follow-up, there was no significant difference in range of motion, function, or disability. So why subject a patient to the potential for disrupting a repair in an early loading phase if there's no difference in outcomes at the end? So not great support for this early motion, and again, this is right after surgery, so a lot earlier than what we would typically follow in a protocol with a repair. Basically, most of this research is looking at rotator cuff tendon repairs. So there's a lot of good research to support our current protocol that we use with a period of immobilization to protect that repair a great deal before we start therapy. So Parsons et al. Did a study looking at whether or not slower rehabilitation after arthroscopic cuff repair led to a long-term stiffness in patients. So there were 54 patients in this study. They all had shoulder surgery, and they were all in a sling for 6 weeks. When they came out of the sling, they were classified as being in one of two groups, stiff shoulders or not stiff shoulders. So treatment didn't matter. Treatment was all the same. And they classified stiff versus non-stiff based on their percent range of motion. All right? And what they found, I think it was a 6-month follow-up, is there was no effect in long-term stiffness. They all achieved fairly good range of motion. What they did find is that those individuals who were sort of stiff after the 6 weeks in the sling, they had an improved healing rate in their tendons versus those who had a little bit more mobility following that immobilization period. And then Bong et al. Did a study looking again at two protocols, limited range of motion versus early passive exercise, and found that there was no significant difference in between groups at 6 and 12 months. And then he did subsequent MRIs and found that there was a decreased tendon healing rate and an incidence of re-tear that was greater in the aggressive exercise group. So again, we see some good evidence both clinically and in the research to support our current protocol to protect that repair and not get these patients moving early, even though we know they're going to get stiff. Even if we can predict it, even if we can say that this patient here, before they have surgery, they're going to get stiff, we're cautious to put them in some sort of protocol that's going to have the potential to disrupt that repair, whatever that repair might be. So identifying these patients early is important, and it's also pretty easy. You typically are going to see these patients with this increased post-operative shoulder stiffness, the ones who've had some sort of repair done. They've been immobilized, they come out of the sling, and they're stiff, more stiff than what you would expect. Occasionally, you'll get the patient who progresses through that second phase fairly well. Maybe they hit the 140/40 and L1 limits within that 6 to 8 week mark, but more towards the end of that. And then after that, they are just real stiff. And then even probably more rare than that, it does happen to those individuals who have arthroscopic tendon debridement, subacromial decompression, distal clavicle excision, no repair, and they are real stiff afterwards. Not typically the case, but potentially it could happen, and it does. So looking at their stage of rehabilitation, and then typically these patients are going to present with a lot of pain, decreased range of motion, and that shoulder is going to be red hot with inflammation. So pretty easy to pick up, usually within the first or second treatment session. Once they've sort of learned to accept you and how you're doing treatment techniques, you can identify these patients relatively early. So the next step is looking at which one of these four, or combination of four things, is causing that shoulder stiffness, because that's going to determine your treatment for their stiffness. So is that shoulder so painful that you can't do anything with them in clinic, they can't do anything at home, and there's a lot of muscle guarding, and then pain's the issue. Is it pain with inflammation? Is it pain and stiffness? Or is it the patient who occasionally is just stiff? You get to their end range of motion and it doesn't really hurt. It just feels tight, feels stiff. And it's like, okay, well, there's no pain, but maybe some inflammation, some stiffness. Or you suspect that there's maybe a little bit of poor healing that's going on. You know, maybe they came in, like Carrie said, without the sling, and they've been opening and closing doors and things like that, or something to lead you to believe that maybe there's a little bit of poor healing. So addressing these causes, pain and inflammation is the big thing, and probably one of the first things you want to look at in getting these patients to sort of move on and unlock their shoulder. And the medication is probably one of the biggest tools that we have in addressing this pain and inflammation, but it's also probably the most underutilized by physical therapists because, we can't prescribe medications, we can't change the medications, but we can communicate with the surgeon and, speak to them about maybe this patient would benefit from having a different medication. Obviously, during examination, you're going to find out what pain medication the patient's on, what anti-inflammatory they're taking, but as soon as you suspect that this shoulder is getting more stiff than what you'd like, you start to inquire a little bit deeper. Okay, are you taking your pain medication? Yeah, I'm taking my pain medication. Well, how often? Every 4 to 6 hours. All right. Does it help? It makes me tired, but it doesn't really help with the pain. Okay, maybe they need a different pain medication. Are you taking your anti-inflammatory? I'm taking my anti-inflammatory. Are you taking it twice a day as prescribed? I'm taking it when it hurts. Okay, well, Voltaren and some other prescription anti-inflammatories are designed to be effective by taking them twice a day, every day. Taking them PRN, you're going to get the benefits of pain relief from the medication, but not the inflammation, the anti-inflammatory effects from that medication unless you take it consistently. So if that patient's taking those things PRN, they might be better suited to take something over the counter, Aleve, ibuprofen, to manage their inflammation if they're just, for whatever reason, not going to take their anti-inflammatory twice a day, every day. And then prednisone, the big one. So if I've got a patient that I know is real stiff, and I don't like how they're coming along, they're taking their pain medication, they're taking their anti-inflammatory regularly, and they're not diabetic, I'm going to talk to the orthopedic surgeon and see if we can't get them on prednisone. And more often than not, that's enough to knock down that inflammation, knock down that pain, and really let me start doing some stuff in clinic that's going to be beneficial to get them back on track, if you will, with their shoulder range of motion. Obviously, as we talked about earlier, cryotherapy is always good for pain release. TENS unit and ultrasound for pain relief. Yep. I threw this study in here by Dagru et al., published in 2008. Looked at individuals who were two different treatment groups who had adhesive capsulitis. The treatments were the same: mobilizations, exercise, home exercise program. The difference between the two groups was one received sham ultrasound, the other one received ultrasound. And at 3-month follow-up, there was no significant difference in range of motion, pain, mobility, that sort of thing. So ultrasound for pain relief, yeah. For realigning collagen tissue, extensibility in the capsule, not quite sold on that based on some of the literature. But for pain relief, yeah, I think it works. So stiffness, the patients who you sort of controlled their pain and inflammation, or they're getting stiff and you address their pain and inflammation through medication, modalities, whatever it might be, then you need to start looking at, okay, what procedure do they have? Are there any precautions in their protocol? And if so, what stage of rehabilitation are they that sort of guide you through dealing with their stiffness? So now I want to talk about specific treatment techniques for getting that stiffness not so stiff. So you've got that shoulder calmed down, you're able to do some techniques in clinic. So what do? Mobilization direction. Now, a lot of the literature I'm going to talk about here in subsequent slides, and with this one too, is the patient population is those individuals with idiopathic adhesive capsulitis. There is not, if any, literature out there looking at specific treatment techniques in increased post-operative shoulder stiffness. Most of it's looking at those individuals who have idiopathic adhesive capsulitis. But I think that those patients with idiopathic adhesive capsulitis and those patients who develop this increased stiffness after surgery, at some point along the rehab paradigm, they sort of blend together. They present the same, they respond to treatment the same. So I think we can sort of talk about these treatment techniques in both categories, depending on what part of the protocol they're in, if there's been a repair or something done. So Johnson et al., this is a study that Carrie already mentioned, looking at the fact that anterior to posterior mobilizations are greater at or better at increasing external rotation range of motion than posterior to anterior mobilizations. Now, Also important to note with this study is that the mobilization techniques they used in this study were Colton board mobilizations. They weren't Maitland mobilizations. So the big difference between those two mobilization techniques is with the Colton board mobilizations, you take up the slack in the tissue and then you hold it there for a sustained period of time. So there's no oscillations like there is with Maitland-based mobilizations. So just throwing that out there, that's what this study looked at. Mobilizations high grade, 3-4 versus low grade, 1-2 mobilizations. Obviously, it depends, again, where they're at in the protocol, if there's a protocol following their particular surgery. This study by Vermeulen et al. Compared both high-grade and low-grade mobilizations in two patient populations and looked at their effect on managing adhesive capsulitis in the shoulder. And what he found was that those individuals that received high-grade mobilizations improved joint mobility and reduced disability greater than those who received low-grade mobilizations. But there wasn't a great deal of difference. So all of the mobilizations, high and low grade, were both effective at improving joint mobility and reducing disability. So don't discount the ability of grade 1 and 2 mobilizations, which are oftentimes used for pain reduction and loosening up, muscle guarding. Don't discount their ability to improve joint mobility and reduce disability in the shoulder, which I think oftentimes we can do. Mobilizations at end range, or EMTs, end range mobilization techniques. See another study here by Vermeulen. This is an interesting study. Now, it's a multiple case report study, so there were only 7 patients in this study, 4 males, 3 females. But he looked at measuring active range of motion, passive range of motion, and the interesting part is he also looked at joint capacity measured through MRI arthrograms of the shoulder. So joint capacity is the ability for the joint to hold fluid. So he looked at that capacity both before and after the treatment. So I think this went on for 3 months, which is probably why he limited his subject number to 7, because doing MRI arthrograms on this population probably didn't get a big thumbs up from the IRB. But anyhow, what he found after end-range mobilization techniques, and these were Maitland-based techniques, was that patients improved active range of motion, they improved passive range of motion, and they also improved in joint capacity. So that may allude to the fact that there may have been some changes in those capsular structures surrounding the joint, as well as some other joint structures that allowed it to hold more fluid. So basically, you did what you were intending to do. You made that shoulder more mobile. So that was an interesting study. Lin et al. Also did a study looking at end-range mobilization techniques. He was measuring the reliability of a specific stiffness measure, but also the outcomes afterwards. And he found that there was immediate effects. So pre-treatment, before the end-range mobilization techniques were performed, and immediately after, there was improvement in passive and active range of motion. So, and again, these were Maitland-based mobilizations, varied in grade, depending on what the patient was able to tolerate. And I think both of these studies by Vermeulen and the study by Lin, familiar with the Maitland techniques, just starts off with some gentle mid-range mobilization, some passive range of motion before getting them into end range or their end range of motion before performing the oscillations, and then after 10 to 15 oscillations moving on to either a different range or a different motion. So how much pain are we going to put these patients through, or how much pain will we let these patients let us put them through? And I think, as Dr. Spear mentioned earlier, there's a real fine line there, and at some point I think we can get too focused on dealing with the shoulder, and then we're trying to improve range of motion, trying to improve function, and it's possible to lose sight of the fact that they're in so much pain that they're not sleeping at night, their overall quality of life is decreased. So we want to consider all that in regards to how much pain these patients are putting themselves through at home, how much pain we're putting them through in clinic, and trying to find that balance between how much pain without sacrificing all those things. So there's a study by Derrick et al. That was done in 2004, again on patients who have frozen shoulder, and they followed them up at both 1 year and 2 year. Now, obviously, we're not going to be seeing these patients, hopefully, post-operatively for 1 and 2 years, but I think the outcomes of the study are interesting. So there are basically two groups: a supervised neglect group, which basically consisted of stretching, exercise, and daily life activities within and to your threshold of pain, not beyond. And then the intensive physical therapy group, which received just that, intensive physical therapy, mobilizations, manual therapy, range of motion, stretches at home, exercises at home. And what they found at 1 year follow-up, the supervised neglect group, 63% of them had unlimited or slightly limited range of motion, mobility in the shoulder without pain. At 2 year follow-up, the intensive physical therapy group had full mobility or near full mobility without pain, 64% of them at 2 years, versus 89% of the supervised neglect group had near full or full shoulder mobility without pain. So 89 versus 64 at the 2 year follow-up. Now again, this is a population that's different than what we're dealing with, frozen shoulder, versus what we're talking about here tonight, and obviously not 1 and 2 year follow-up. But it kind of makes you think a little bit about how much pain you inflict during therapy or allow them to inflict on themselves at home. So just something to keep in mind. I thought it was an interesting study. Probably one of my favorite clinical commentaries in regards to frozen shoulders is by Martin Kelly et al., which was published in JOSPT, and he looked at a comprehensive approach similar to what we're talking about tonight, based on the individual's presentation, and then sort of a hierarchy of pain relief, manual therapy techniques to help improve their range of motion, exercise, and then restoring functional range of motion. So basically the paradigm that we typically follow. And I talked to Martin Kelly about the patients he sees at the Good Shepherd Clinic up in Philly, and he sees mostly non-operative shoulder stiffness in that clinic. So we talked and we sort of agreed that there is definitely some blending between these two patient populations, those individuals who have stiffness after surgery and those who present with idiopathic frozen shoulder adhesive capsulitis, that at some point they sort of present the same, and that the treatments that we use have the same efficacy in both groups. So one thing I really liked in his study, that he is a clinical commentary, was that he classified patients based on their irritability level. So he looked at how high their pain was, the frequency of their pain, their disability based on several outcome measures or disability indexes, what their pain was like at end range of motion or in regards to end range of motion, and then active versus passive range of motion. So typically, probably what we're going to see in regards to what we're talking about tonight are patients that fall in the high irritability and moderate irritability category, not necessarily low irritability because they wouldn't present with what we're talking about. So taking this classification, he developed, along with the other authors, treatment strategies based on those levels of irritability. So 3 things I really like that I think we can take from this and apply it to the group of patients we're talking about this evening is, first of all, the range of motion / stretch category. In his clinical commentary, he talks about the TERT principle, the total end range time, so the amount of time that a patient spends at their end range stretching, whether it's in clinic or at home, and looking at that as sort of a dosage that we can either increase or decrease based on how the patients respond to that TERT principle or their total end range time that they're spending stretching. So you can see that, with this high irritability group, he's suggesting that maybe we do a real short duration, 1 to 5 seconds, pain-free passive active assisted range of motion, just to kind of calm those nociceptors down, get a little bit of passive motion going, but definitely different than what we're used to as far as holding a stretch or having the patient hold a stretch to gain extensibility in the tissue. But this is different because these patients are presenting differently than the normal population. And obviously that duration increases in a moderate irritability classification, and you do passive and active assisted range of motion as well as active range of motion. Also, I like this manual therapy technique category because, again, we talked earlier about high versus low-grade mobilizations and their effectiveness at increasing range of motion and decreasing disability. And he's suggesting that in the high irritability group, it may be more suited for low-grade mobilizations versus the moderate irritability group that is more well-suited for low to high-grade mobilizations. And this is probably because the high irritability group just can't tolerate the higher-grade mobilizations. And obviously, we're hoping or suspecting that these patients sort of move from one category to the other as we treat them in this manner. And I also like the strengthening portion as we see some dashes here in the high and moderate irritability because that should not even be on our radar. Because at this point, we're just worried about getting that shoulder moving. First off, protecting the repair if any was done, and then getting that shoulder moving. If that shoulder's not moving, it's not getting stronger. So that's not the main focus here. So really like those two things from his study. It's a great read for a clinical commentary just about adhesive capsulitis and a lot more things than what we talked about here this evening. So when we see these patients that we suspect have increased shoulder stiffness after surgery, there's sort of this clinical thought process that we might find ourselves going through. First, understanding the predisposing factors. Before we even see the patient, if we have the op report or a little bit of history, we can sort of identify those individuals who may be more likely to develop post-operative shoulder stiffness. Not all the time, but there's a good chance. Knowing the precautions based on the procedure they had done. So knowing the procedure in detail and the protocol that limits range of motion, limits mobilization grades, things of that nature. And then their individual presentation. Why is their shoulder getting stiff? Is it pain? Is it stiffness? Is it inflammation? Is it poor healing? Is it a combination of more than one of those factors? And then knowing those and understanding how to treat those individual factors. Pain and inflammation with sort of the medication that we talked about or certain modalities. Manual therapy, we talked about the fact that anterior to posterior mobilizations versus PA mobilizations are more effective at increasing external rotation. We looked at low versus high-grade mobilizations and end-range mobilization techniques, or EMTs, at increasing joint mobility and decreasing shoulder disability. And then therapeutic exercise, which, again, we didn't really talk about. But once that shoulder sort of gets unlocked and you get them back sort of on track, if you will, where they should be in that rehab process, I think that the introduction of therapeutic exercises, as soon as the protocol allows and as soon as the patient can tolerate, can really help to keep that ball rolling on improving their range of motion, as opposed to, okay, we've been working on getting this shoulder moving. Now it's getting moving a little bit. Let's keep going. That's important. Keep doing those manual therapy techniques and all that stuff, but getting a little bit of therapeutic exercise in there can really help that joint to get a little bit more mobile than just sticking to those manual therapy techniques once you feel like that shoulder has gotten a little bit unlocked. And then finally, communication. It's so important in what we do and should be intertwined throughout this whole thought process. Right from the initial evaluation, patient presents, post-op rotator cuff repair. They've been in the sling for 3 weeks. They're diabetic. They had a frozen shoulder beforehand. They had a lot of pain, limited range of motion. It's good to be upfront with those patients. This could be tough, and it probably will be tough. It's going to be tough for you. It's going to be tough for me. And then letting them know throughout the process, just coaching them along and constantly communicating with what you find so that they're on board with it and they can sort of buy in and know that they can confide in you and that you're sort of in this battle together with them. So with that, it's Thank you all for coming out again, and we'll open it up for some questions.
What type of incidents have you found of concomitant rotator cuff tear with those people?
The question is the concomitant rotator cuff tear with a proximal humerus fracture. My experience is that the incidence of a traumatic rotator cuff tear that occurs concurrent with the fracture is remarkably uncommon. And that generally, if the patient has some persisting pain or cuff dysfunction, and we image it, there's a cuff tear, there was a pre-existing degenerative tear. It's always remarkable. The shoulder seems to break down in a certain pattern. I mean, that you wonder why couldn't a fracture have an associated tear? It's very, I would have expected it to, but I just haven't seen it. So the traumatic, but a lot of time MRIs do show tears, and when I've had those patients and then I've operated on them, that tear is old. So I think that it doesn't occur, although it may have been asymptomatic, and then with the trauma and the stiffness, now asymptomatic.
For the therapists, you didn't hit much on soft tissue treatment with physical therapy approaches. If the muscles are starting to get myofascial restrictions and trigger points, how much do you find that those restrict mobility as well as the capsule?
So I think that there's definitely the presence of that increased soft tissue tightness, myofascial pain in those individuals we're talking about with the increased post-operative stiffness. And I think that in combination, maybe with ultrasound, but definitely trigger point release, soft tissue mobilizations, I think that is definitely, it falls into that pain inflammation category as to what's causing their shoulder to be stiff and it needs to be addressed. Because if those muscles continue to guard, you're never going to get at the capsule. If those trigger points are there and it's just so painful and guarded, you're going to develop more problems later on. So I definitely think there's some efficacy and some research to support that. Dealing with those soft tissues, including trigger point release, definitely help.
Do you think sometimes soft tissue restrictions can be confused with adhesive capsulitis? And if so, how would you be able to distinguish if that is possible?
Yeah, I think they can be, and obviously it depends on the therapist and the presentation of the patient. I think the big factor there is assessing the end field. When you reach their end range of motion, what's available? What do you feel? What's limiting it? Are you getting some contraction or some convulsing of the muscle and its muscle level? If you get to that point and it's just stiff and it makes sense in your head capsularly based on shoulder pathology, as Kerry talked about, the celiac pattern does not hold true in a pathologic shoulder. So that concave-convex rule doesn't hold true. Mm-hmm. So if you've identified areas of stiffness on your exam and it matches with that capsule and you don't get that guarding, I think that's a good way to identify that. And then as well as palpation on those muscles, identification of trigger points, and where the pain is and how it presents. Typically with soft tissue pain, it's going to be pretty specific or follow a certain pattern. With adhesive capsulitis, that's a little different. It's more positional depending on what stage they're in. Adhesive capsulitis.
Question?
Brisman procedure. Have you used any of that for adhesive capsulitis? The Brisman procedure?
Question is about Brisman, or I would call it Brisement.
No. I.e. tomato.
Right. So, the Brisement procedure for adhesive capsulitis. First off, most people probably don't know what it is. When a shoulder gets stiff, a shoulder gets stiff differently than a knee gets stiff. When a knee gets stiff, you get a lot of arthrofibrosis. That retropatellar tendon fat pad gets fibrotic, adheres to the front of the tibia. it's a lot of space occupying fibrous tissue. In the shoulder, it typically is different. In the shoulder, the capsule, the analogy I tell patients is that the shoulder capsule is normally about as thick as an apple peel. In a frozen shoulder, or adhesive capsulitis, or a shoulder that clearly has a capsular pattern of stiffness, it's not that the joint is filled with scar tissue, because I mean I've scoped, I know what it looks like. Instead of the capsule being like an apple peel, it's like a watermelon rind. The capsule thickens and it gets real thick. It can get 5 millimeters, 8 millimeters thick, and so it's like the joint volume gets shrink wrapped. So historically, and I think this is historically, there was a procedure that the notion is that, you know, what you're trying to do in physical therapy for that type of, say, adhesive capsulized frozen shoulder, the capsule has to be disrupted. You know, you have to get the range of motion back. You have to disrupt the capsule in some manner, and that's through applied stretching and mobilization. Well, an alternative pathway, how about if we put water in the shoulder, or some liquid, usually it's water, and then just under high pressure you push until it kind of, you know, push. It kind of explodes. That is really not done anymore, or at least I have not seen it done anymore. One of my mentors when I was in training still did it, and it really didn't work well. It was enormously painful. Enormously painful, and usually they just blew it out through the rotator interval anyway. So the rest of the capsule, it just was, it was sort of ineffectual, and I don't think it's done much anymore. And it is to be done effectively. You almost have to be done under anesthesia. It is painful. It's not something to be done casually.
So with that note, what about your lysis of adhesions? You know, when you go in there arthroscopically, in that case, are you finding that there are the arthrophyretic adhesions that you're releasing, or is this just a closed manipulation?
Well, so the question is about the stiff shoulder, frozen shoulder, or some maybe shoulder that's had surgery and they remain stiff, and now they've failed to recover in spite of physical therapy, in spite of everything. So, in those patients, I prefer arthroscopic capsular release, because again, what you're trying to do is that capsule is tight. You have to disrupt it. You have to stretch it, which is, you know, micro tearing it essentially. Well, I sort of macro tear it. I mean, you just cut it and cut the front, cut the back. Excuse me, and that allows the shoulder to move. Usually the capsule, it might be 5 millimeters thick. And that alone will enable the shoulder to move. What's interesting is the passive motion loss in the shoulder comes from the capsule, not the perihumeral space, not the subacromial space. Your subacromial space could be chock full of scar tissue and bursal adhesions and fibrosis. Excuse me. And you could have a painful range of motion, a crepitant range of motion, a difficult range of motion, but your passive range of motion is generally pretty good. So yes, that's what we see, and we get them in physical therapy. When I tell them, I said, the arthroscopic capsular release removes the barrier that you and your therapist couldn't get beyond. So I can get the motion. Left over here. It enables the physical therapist to work with the shoulder. And whereas before surgery, you were trying to regain the motion, after the arthroscopic capsular release, you're trying to maintain the motion. Still the same therapy. But the idea is that the shoulder has a capacity to move. And hopefully you can maintain it so it doesn't scar back down. the questions? I think I got my choking out of control. You know, the one other thing I would mention before we close is I see a lot of patients. I asked my medical assistant when she puts patients in the room. I said, you know, 3 words or less. Just write something down. You know, just ask the patient how you doing. That's all she says. I said, just 3 words or less. You know, I don't want. I mean, it's almost like the, you know, the Homeland Security colors for threat risk. I mean, I just want to know. You know, I mean, is it? You walk into a room. Is it? You know, is it great? Is it good? Is it bad? Is it terrible? Whatever it is, it kind of lets me focus on what level they're at. And sometimes patients are doing poorly, and because they're doing poorly, they really are. I mean, they're excessively stiff. I'm not doing a very good job controlling their pain. I mean, there's also the myriad of things I got to address. But sometimes patients are coming in, and Mary might write, you know, very painful or doing poorly, you know, and they've just finished the first phase of physical therapy. They had a cuff repair. They're at 7 weeks post-op, finished phase 1. Our objectives are hopefully 40 of extra rotation, 140 of elevation. You know, I come in and say, you know, so well, your shoulder's struggling. Oh, yes, Dr. Spear, it's this and it's that and da da da. You know, it's a great sort of pall over the discussion that the patient is clearly convinced they're doing poorly, and I'll assess them. You know, and their external rotation is pretty good, I mean, 20 to 40 degrees. The rotator cuff is smooth, it's healing nicely. And I spend a lot of my time trying to convince them, you're doing good. You really are. You know, you're 7 weeks after surgery. This thing takes a long period of time. And you're, you know, where you're supposed to be, it's a certain pace. You know, and where I want you to be is where you're at. And I think that's one of the things that I think is part of the art of physical therapy, is keeping patients' interpretations of their progress real according to their progression. I mean, if I did a total shoulder replacement, and they're at 7 weeks post-op, and you know their shoulder's been arthritic for 10 years and haven't moved it much in 2 years, and after the first phase of rehab, they're coming along a little bit stiffer than you'd like. You know, shoulder's real weak, and the patient are going, "Oh my God, my shoulder's weak," and all that. It's like, whoa, you know, we need to reset how we're going to interpret this. So I think that part of it is setting patient expectations, and many times for some patients, I have to reset it every time. I'll tell them, I'll try to convince them, because part of it I'm trying to coach them up. You know, it's like I become one of my old football coaches. You know, you're doing well. You are doing well. It hurts. Yeah, it's supposed to hurt. But, you know, your rotator cuff is healing. The motion's where it's supposed to be. You're tolerating your medicine. And where I would hope you would be, you're about at that point. So it's, you know, it's good. It's not bad. And some patients, you know, in spite of preoperative teaching and therapists repeatedly talking to them, you know, they're 6 weeks into something that's going to take 5 months, and they're despairing because their shoulder's not moving. And the best remedy for that is to try to sort of, once again, you know, somehow communicate to them in a way that gains traction, that they understand. And it's easier said than done. It really is, because I get a little. I mean, some things I almost have to, you know, get defensive with them. I mean, I said, listen, you know, you're doing well. You know, your shoulder's coming along well. I mean, you know, this has been a condition. As one anecdote, a patient who had a rotator cuff repair 3 years ago. She got very stiff after surgery. This was done, Elder's workman's comp case, one of those. And very stiff, dysfunctional, painful, probably lacked 30% end range of motion. They got an MRI, her cuff had healed, but she just had a very stiff, dysfunctional shoulder. And it was just, you know, and she's a relatively young person otherwise, and you know, and I thought, you know, she's needful. If we can get her range of motion back, I think her shoulder's capacity to do much better. You know, her cuff is healed. She didn't have arthritis. And so we did the surgery. And I saw her back at the 5 week mark just recently, you know, and her motion is excellent. really, it's better it's been. I mean, she probably had about 150 degrees of elevation at 5 weeks. She probably lacked maybe only 10-15% in range of motion. Pretty good, considering it's been fixed that way for 3 years. And oh my God, you would think the world is ending. Oh, it's terrible. Oh, this, that, and the other. I said, you're not going to get better, until you get a better approach to this. I mean, this is tough, but you're doing well. But this is going to be, So many times I think as clinicians and therapists, and the art of medicine is somehow, encouraging the patient, educating the patient, getting these people to believe they can do better, because the shoulder is so rehab sensitive. My God, it's rehab sensitive. More so than most any other joint. I mean, I have no doubt that my hand surgery colleagues will tell you that hand surgery may be similar. It may be. But God, the shoulder's rehab sensitive. And I can do everything that I can do. And I mean, surgery is merely the enabling of the shoulder to get better. That's all it is. Rarely, with the exception of maybe like a clavicle fracture fixation, something like that, where you fix it, watch it, heals, gone. Most everything else, that shoulder may be healed, but it's not recovered. And the patient's outcome determination is recovery, not healing. So, but that's why it's challenging. That's why people want to meet and discuss it, and that's why I think it's so the better that therapists can understand and deal with the shoulder, the better outcomes people get, even if the surgery doesn't go great. Even if things don't heal as well, or things aren't as good as it can be, still the shoulder can be rendered much better with great therapy. So, I know there's a spectrum of philosophy amongst orthopedic surgeons and how they would speak to that. And I think I'm on one end, and I'm obviously a big advocate. But there's some of my colleagues who won't even use physical therapy, and I mean, I don't really argue much with them, but I think the shoulder is enhanced with as much structure and as much professional guidance as you can apply, and the insurance will allow. Essentially, so sometimes we have to adjudge balance things. The patients can't afford co-pays or their insurance is running out, and at some point, we're dealing in a world that we have to deal with it as we find it. But I think that what physical therapy does to the shoulder is superb, and thank you all for coming. And I know there's a couple house cleaning things, because you guys got to fill out those forms so that your credentialing body will allow you to get the CEUs that you are expecting. So thanks. If you have any other further questions, come on up and talk to us. Otherwise, have a safe drive home.
Thank you. Thank you.